Hey everyone, my name is Mike Loria, and this is the Nurse Code Captain, Applications of Cognitive Science to Improve In-Hospital Resuscitation. So by way of background, my name is Mike Loria. I started out in healthcare as a firefighter EMT back in the early 2000s and eventually enlisted in the Air Force. I was a pararescueman in the Air Force. My job was to provide combat search and rescue capability to various special operations teams, as well as direct action support to those teams around the globe. And I got out in 2011 and started working as a critical care flight paramedic for the Dartmouth Hitchcock Advanced Response Team, and then eventually had some amazing mentors there that convinced me to go to medical school. I graduated from Dartmouth in 2018 and decided to do residency here in New Mexico, which was absolutely amazing. Fantastic training. Stayed for fellowship in emergency medical services and am currently a critical care fellow. But despite my best efforts, I can't get enough of flying and I still am engaged with the UNM Lifeguard Critical Care Transport Program. By way of disclaimer and disclosure, I am the Associate Medical Director for UNM Lifeguard. I work for a company called Flight Bridge Ed as their Chief Medical Director and help with their content and some of their educational stuff, and have no other financial disclosures or conflicts of interest. This talk is about thinking about cognition and human performance in resuscitation, or how we go about developing better systems, understanding how our brains work, how we think, how we act, how we interact with other people, and how we interact with our environment in these really stressful situations, and particularly in the setting of in-hospital resuscitation, and how I think, especially when it comes to cardiac arrest in hospital, nurses actually leading the codes can be a good thing and is in line with best practices in terms of human factors engineering and cognitive science. So I want to talk a little bit about the science of stress and cognition and how we think in these really challenging environments, and then talk about team resource management or applications of a concept called crew resource management during in-hospital cardiac arrest. And finally, the nurse captain and how I think it's a very viable and potentially helpful option under these circumstances. So when I was in the military, we did a lot of very high-risk things on a regular basis. The special operations community has done a really good job of figuring out how to take very high-risk operations, standardize them, train them very well, and make them relatively routine. And it was in thinking about that and really thinking about how I was performing in those situations that I started to think about how the human brain performs and thinks in these very stressful circumstances. And as it turns out, this led me down the path of doing a lot of reading and research and applying it and trying it over time while I was in the military. Sure enough, while I was getting out and working as a flight paramedic, I tried to develop a lot of these concepts and apply them to clinical medicine. And then throughout residency and fellowship, the same thing. And I really think there's a place for understanding this, and it's a big opportunity for improvement in the way we provide resuscitation in the emergency department, in the ICU, and essentially everywhere in the hospital. So let's start out by talking a little bit about stress, cognition, and human behavior. So when someone's really sick, and especially when someone codes, it could be a pretty stressful situation. And stress, at its very core, the perception of acute stress, not chronic stress like we experience from fatigue in our jobs, or what was going on during COVID, but an acutely stressful event. Patient codes right in front of you. We think the way that it works is actually something called this appraisal mechanism. And what your brain is constantly doing is this sort of math, and it's asking yourself, do you have the faculties? Do you have the resources necessary to meet the demands of the situation presented to you? So if you're a brand new physician or nurse or respiratory therapist or paramedic, and you've never been to a code before, and you walk into the room and people are looking at you and yelling things at you, and you really don't know what to do, you perceive stress. And what you may feel is this feeling of being outmatched or not in control. And essentially, you're just trying to not screw up. You're trying, as we say, to not playing to win, but you're playing to not lose, trying not to screw up too badly or have people get pissed off at you. And your mind focuses on not making mistakes, or mistake avoidance, as we call it, and often often gets fixated and preoccupied with details that are unimportant. You're less engaged actively in trying to get a positive outcome, not as purposely, but accidentally, because you're just trying to avoid getting yourself in there and screwing things up. This is this conservative and avoidant mindset, which we really don't want to see when it comes to emergency situations. We want people to be engaged. We want people to jump in there. We want people to help out. And this is what's called the challenge mindset. So flip that around, and let's say you've done this a million times before. In fact, maybe you're researching it or you're very interested in it, and there's an in-hospital cardiac arrest, and you are right in there. You know exactly what needs to be done. You're leading the pack. You're telling other people what to do. This is the challenge mindset. Your mind knows that you have the resources, you have the ability to tackle this situation and knock it out of the park, and you're all in. It's this perception that you're likely to succeed, or you have at least a fighting chance of doing your best. You're playing to win. You're focusing on what can be gained or achieved and a positive outcome for the patient. You're less hung up on your own performance or unimportant details, or perhaps making a mistake. You bring positive energy to the table. Your approach is aggressive and goal-directed in terms of your behaviors and your language that you use during the event. That is exactly where you want to be. That is the challenge mindset. And what's important to understand is that stress is not just this feeling. There are very distinct physiologic, cognitive, and behavioral changes under acute stress. Literally, the chemistry and the electricity of your brain changes. And what we see is these various effects that are somewhat unique to the situation. So we hear people describing these changes to your faculties, like this, what we call the slow motion effect, that you feel like time is moving in slow motion. You say, oh, we were in that room. You think you're in a room running a code for 10 or 15 minutes. In fact, you're in there for an hour. It's the slow motion effect. People have experienced auditory exclusion under these circumstances. There's a lot of these black box recordings where a co-pilot is telling the pilot something like, hey, the landing gear's not down, or hey, we're too low. And you hear the pilot saying things like, okay. But in reality, the pilot is so stressed out that even though they have these passive responses, they're not processing it. And even in retrospect, if they survive, they'll ask the pilot, do you remember the co-pilot telling you that the landing gear was down? And in interviews, people will say, no, oh my gosh, I don't remember that at all. Your attentional capacity changes. It fundamentally changes. Normally, I tell people your attentional capacity is like a flashlight. It's either a very focused, narrow, bright beam, or it's very kind of wide and diffuse. And as it turns out, it's hard to manage that attentional capacity when you're very, very stressed out. And what we see is something called the cognitive science term for this, and in human factors engineering, it's called increased selectivity. The common colloquialism that we use is getting tunnel vision. So you're overly focused on details that aren't necessarily that important. And you have issues with your working memory as well. So it is actually more difficult for your brain to pull pieces of information out of long-term memory when you're really stressed out. And you may have experienced this before, when suddenly someone asks you a question in the classroom or on rounds or at the bedside, and they say, what's the dose of this drug? And you know it. You've given the drug 1,000 times. You know the dose, but you're caught off guard, and you're in the front of a bunch of people or an entire classroom, and all of a sudden the answer just disappears from your brain. You can't remember it at all. You feel stressed out. You can feel your heart rate going up. You feel your palms get sweaty. And it's like your memory just completely goes blank. That's actually a very normal effect that people experience. And we know that your working memory is substantially impaired when you're stressed out. Likewise, normally your brain can figure things out pretty quickly. If I gave you a test question in a calm, controlled environment where I gave you several patients, one had toe pain, one was missing his head, one was complaining of a mild bellyache and nausea, and another person was in respiratory distress, and I asked you which patient needs to be treated the first, right? You would very easily say, oh, is the patient in respiratory distress? Airway, breathing, circulation. Breathing is an emergency. Someone who can't breathe is an emergency. I need to take care of that one first. However, when you're stressed out, that ability is impaired, and we see people getting overly focused on things that are not that important. So actually a combination of that increased selectivity and poor mental triage or impaired mental triage is actually quite dangerous. Ironically, you have increased distraction. So again, this is sort of a paradox. Yes, you have increased selectivity, and yes, you get tunnel vision on things, but it's actually easy to get you distracted and get you tunnel vision on one thing, and then another thing, and then another thing, and then another thing. So you're more distractible under these situations. And your brain has difficulty solving novel problems. We call this cognitive perseveration, or the broken record effect. If you've ever seen someone doing something over and over and over again, despite the fact they're clearly not getting anywhere, they're poking the same arm, desperately trying to start an IV, or the new intern who is not intubated someone, real humans very much before, is kind of just flopping around in the mouth with the laryngoscope, and they're not necessarily demonstrating goal-directed behavior, and they are experiencing multiple of these effects. But the cognitive perseveration is when your brain is super stressed out, it can't solve novel problems very well. So it defaults to the only thing that it knows. And sometimes that thing is just doing the same thing over and over again, which is not super effective. Now, there are specific examples in medical emergencies, as it turns out. So we've tested this in paramedics and doctors, looking at people's computation ability to solve simple math problems. Beforehand, totally fine. In the stressful scenarios, and even after the stressful simulated scenarios, that's actually compromised. They tend to make more mistakes and take longer to solve the problems. Also, we've actually tested this in the world of emergency airway management. As it turns out, people have very poor time awareness. When this was actually studied, emergency physicians intubating people, they actually stated that it took them they thought that they were about 50% faster than they actually were. In other words, if it took them a minute to actually intubate someone, it actually took them closer to 1 minute and 30 seconds, which doesn't sound like much, but if you're talking about a more difficult airway, that's minutes, that is a big difference. What's even more concerning is when people were asked, did you notice the patient became hypoxic, or did you notice when the patient became hypoxic? Most people didn't even recognize it. They didn't even know that the patient had become hypoxic because they were so focused on getting them intubated. As it turns out, we've actually evolved with the ability to adapt to the situation. So we can actually look at EEGs of people when they're presented with an initial very challenging problem or challenging, hard situation that stresses them out a little bit and gets them aroused. And over time, as they become more comfortable, their EEG actually changes. We also know that the centers of the brain, such as the amygdala, that deal with activation of the hypothalamic pituitary adrenal axis, as well as increased tone in the sympathetic nervous system, over time, as people are exposed to these very stressful problems or challenging problems, stressful scenarios, we think that they actually are able to have decreased output or decreased stimulation from the amygdala, and that seems to correlate with things like their heart rates don't get as high, their heart rate variability, and other physiologic signs of stress are actually improved. Perhaps what's most interesting is that there are some initial studies looking at the development of neuromodulatory peptides. So over time, the hypothesis, again, this is not proven, but there is a hypothesis that individuals actually develop the ability to express peptides that modulate transmission in the amygdala and hippocampus that actually, under acute stress, they are able to, this causes that change in the activation of the amygdala and the hypothalamic pituitary adrenal axis. They don't get that same epinephrine dump as other people do because they've become used to the situation. That kind of makes sense, right? We've all experienced it where if we've been in the emergency room or we've been in the ICU for a long time, we are less likely to get super stressed out when we are presented with someone who's super, super sick because we're kind of used to it. Now let's talk about team resource management. Why is this important and why am I talking about this today? Well, as it turns out, codes are very stressful, high cognitive load situations. And managing your team resource, just like the teachings in crew resource management, the same things that we teach to air crews, and also there are programs in the world of anesthesia and other acute care scenarios where we are teaching people about these same techniques and same ways to behave and manage in very stressful situations and still perform at a high level. So really, what I take out of that, if you look at all these training programs for crew resource management and team resource management, the most important resource really that you're managing is this bandwidth in your brain's ability to process things when it's really stressed out. And the way I kind of think of it is kind of like the bandwidth of the internet. So if you imagine like this is the bandwidth of an internet cable going to your computer, and you start watching a YouTube video, and then you get distracted and you're watching another video, and then something else happens, you're processing things and you're answering emails, and all of a sudden your RAM fills up very quickly. And the same thing is kind of true with your working memory. At any given time, it's kind of finite. And so as you start to think about all these things, oh my gosh, this person coded. What happened? Why did they code? Is someone getting the Lucas? Is someone getting the code card? All of these things fill up and saturate your working memory very, very quickly. So this is really about managing that cognitive load. And there's several ways that we can do this. And we look at engineering these situations and training that focuses on how people can manage this cognitive load. We kind of think of it as in three chunks. We can prioritize what we need to look at and the cognitive load, or what it should really be taking up our cognitive load, managing the remaining load, and then sharing some of that cognitive load. And so prioritizing, we've stolen this too from the world of aviation. This is from a former fighter pilot and fantastic emergency physician who basically came up with this idea of resuscitate, differentiate, and communicate. And this is Dr. Joe Novak, who's also has taken this from the aviation paradigm of aviate, navigate, communicate. Keep the plane in the air, get to the right place, and communicate with other assets. And in emergency medicine and the ICU with super sick patients, it's resuscitate them, get them back, get their blood pressure, get their heart pumping, get them breathing again, differentiate, figure out what the underlying problem is and how we're going to manage the situation, and then communicate and coordinate with other consultants, get them to the right unit, get them the interventions they need, etc. And so essentially it's like triaging things. And specifically when someone's really sick, it's triaging what's the most important thing. Okay, you got to stop the bleeding. Okay, then we got to help this person breathe. Then we got to do all this other things that we're regularly taught in a lot of these classes like ACLS or ATLS, etc., etc. Managing the cognitive load, in other words, managing your own cognitive load, there's a lot of things we can do there. So we can develop automaticity. It's actually, as you get used to doing simple tasks like starting an IV or putting on the defibrillator pads, it's kind of like walking and chewing gum. If you actually develop muscle memory, or colloquially what we call muscle memory, I don't like using that term because it's really very little to do with the muscles and more to do with how your brain myelinates these pathways and develops these pathways so that these skills become essentially automatic. You can do the skills very quickly with very little cognitive load, whereas someone who's very new has to focus on all the steps. They put a lot of brain energy into the individual task. Becomes automatic, doesn't take up a lot of load, and then you can actually think about other things and talk to people and do other stuff. Standard operating procedures are also a way to manage that cognitive load. When there are standards and clear mechanisms for doing things like the ACLS algorithm for VTAC and or pulseless VTAC and VFib, right? Everybody knows what that algorithm is. Everybody knows that they need to see if do they need to shock it as soon as possible. Everybody knows like what the steps and medications you would use in that. That means we have to think about it less. There's less room for novel processing because we know exactly what we need to do. There are psychological skills as well. So performance psychologists have worked with athletes and in the military with NASA astronauts to basically teach them psychological skills for managing the stress. And you can see this with Olympic athletes. There are various programs in the military and NASA that teach us how to deal with these situations by using controlled breathing, positive self-talk, to use mental practice, seeing yourself doing these skills, and trigger words like focus to transition you to actually push you into action. These skills can be learned and applied on an individual basis. There's other cognitive offloading tools like checklists and reference material, so you don't have to think about or Google what the drugs are for a particular emergency. They're right there on the paper in front of you. That's particularly important. And then you can engineer the environment around you to make it easier to find things, color-coded airway carts, different other surgical skills carts that have everything set up in pre-made packages. So everything you need for a chest tube is ready to go. Everything you need for an arterial line is ready to go. You're not spending time looking for different airway devices and pieces of equipment because it's very easily laid out for you. Likewise, the organization of personnel. So where people stand, if it's standardized and they move right to those locations, you can know just by looking around the room who different people are and what they're doing, what their job or their role is. That's actually very helpful as well. And lastly, share. So sharing part of this load is actually very important. So you can delegate tasks to other people. Hey, get into the computer and see what their last set of vital signs were. What medications they take? What were their labs several hours ago? Communicating with other people that can come and help offload you, running things by specialists. Hey, this is what I got. What do you think about this situation? Or what do you think about changing our treatment plan like this? And something called shared mental models. So shared mental models are structured, organized ways that your brain thinks about a particular procedure. And when we have a mental model that revolves around a particular ACLS algorithm, for example, we know that there's supposed to be someone running the monitor, someone pushing drugs, someone on the airway, someone doing compressions or monitoring the Lucas. That shared mental model becomes this organized, shared standard among everybody in the group, and everybody actually does things more efficiently. They're able to anticipate and predict what people are going to need. So I see this all the time. Whoever's pushing drugs, they're coming up on 3 minutes. Our amazing pharmacists are already pulling drugs, have the epi ready for them, and know that the time is coming up, so they have it ready to hand right to the nurse. That's exactly what a shared mental model allows you to do, and it's super, super valuable. So this whole concept of the nurse captain, why is it important? And what do I actually say when I mean the nurse captain? What I mean is having the nurse essentially orchestrate and run the entire code, especially the pieces of the puzzle, making sure that we're getting the pads on the patient, that we're minimizing interruptions and compressions. They are essentially driving the train and organizing all of the people around them. That's really, really, really important. So instead of having a physician do it, I think it's valuable and probably a good idea to have the nurse do it. And when I think about this as the nurses pilot the ship, so they manage the logistics and keep things going in the right direction, and the physicians are managing the fleet. In other words, looking outside of the situation, thinking about things like, is this patient an ECMO candidate? What was going on? What's the underlying problem here that we have to treat? It frees up our brains to think on another level about how we're going to manage this patient when the nurse is so excellently and so amazingly running all the pieces of the code, making sure all the drugs get in at the appropriate intervals, making sure the patient gets shocked. So I think that's actually really important. This old model, if you guys remember the old days with the AHA videos, and there was some guy there at the foot, some male physician there saying, okay, so-and-so at the head, good job with bagging the patient, good job with chest compressions, Janet. That model needs to go. The idea of that it has to be a physician running things is absurd. The idea that a physician is any better at telling someone it's time to shock or telling someone to do chest compressions deeper is ridiculous. And it's not an ideal use of someone's training and brain power. So not to say that nurses or paramedics or respiratory therapists have any less brain power, but the physicians are often very familiar with the overall training plan, and it's not the training plan, but the medical treatment plan. What was going on today? What was supposed to happen to the patient? What did we change in terms of their medications or other interventions? What were we concerned about in the back of our minds? What did their labs look like, several hours ago? These things are important to separate out from running the logistics so we can focus on that. Now, why might nurses be ideal for this position? And I will say, I say nurses, but really it can be essentially anyone else. The idea of just having two brains, two people, one thinking about big picture and the underlying problems and what you're going to do, who you're going to coordinate, where this patient is going to go, talking to the family, and the other person essentially thinking about the mechanics, the logistics, how things are going. Is the Lucas getting on? Are we shocking the patient? But in general, actually, some places have had a significant amount of success with this idea of nurse-run codes, and I actually think it's a very viable option, and there is some literature to support it. So here are the reasons that I think it might be a very good idea. Reason number one, it's totally within the nursing scope of practice. Nurses take this exact same ACLS course as paramedics, as respiratory therapists, as physicians, as everybody else. They know the algorithms. They can look at the algorithm just as easily, and they have plenty of experience doing it. So it's totally fine and totally appropriate and within their scope of practice. As it turns out, nurses are excellent at managing logistics. There's some evidence that actually suggests that nursing leadership is a beneficial resuscitation quality. It shows that nurse leadership during a code is actually pretty helpful because it can reduce crowding in the rooms and increase clarity of communication. So that's really, really important, which brings us to our next point: optimized communication. So as it turns out, and not surprisingly, nurses are very good at speaking their mind, advocating for patients. And in crazy, very hectic situations, when we've studied it, nurses do an excellent job in fact, just as good as physicians, in terms of getting their point across, telling people what to do, asking and probing with other people involved in the code what they need and how to get things done. It also is very good and has some peripheral benefits I shouldn't say peripheral, direct benefits in terms of empowering the staff, giving people control and making them feel like they have an important and, in fact, critical role to play is very, very important. And furthermore, we have looked at high-performing hospital teams with the best in-hospital cardiac arrest survival statistics. And in these hospitals, as it turns out, the cardiac arrest survival rate is actually higher when we empower nurses, put them in leadership roles, and actually give them very important part to play in terms of managing cardiac arrest, as well as other administrative roles around the institution and significant roles in terms of how these cardiac arrest teams are managed and how the data is collected. It improves situational awareness. So it's very interesting looking at this. Again, remember, if your brain is completely saturated, if you're simultaneously trying to look at the labs from earlier and run the code, what we see is people don't even pick up on things like, hey, it's been more than 10 seconds that we've been pausing chest compressions. Hey, did anybody think about putting in an LMA and bagging this patient? Hey, did anybody think about this or that? You can't really process that or notice when things aren't going well or things are being done inappropriately because your brain's so busy thinking about other things. And this is where that two-brain model for complex high cognitive load situations comes in. Again, one person focusing on the details and driving the ship, and the other person focused on the big picture, where the ship is going. Finally, nurses can perform rapid task switching as well as physicians. Now, this is very interesting, and you'll notice I use the term rapid task switching because we used to say, we used to call this basically multitasking. And as it turns out, we weren't multitasking at all. We weren't managing multiple tasks simultaneously. We were just switching very quickly between tasks. So in terms of managing a bunch of tasks, degrees and intelligence and knowledge when it comes to medicine has absolutely nothing to do with it. And nurses are just as good as managing the situations and switching rapidly between tasks as physicians are. I would add that it's particularly useful in low resource settings and when starting advanced therapies. So on the one hand, in very low resource environments where you may not have a board certified emergency physician or intensivist or someone who's run a lot of codes, you may have a family practice physician or someone who's not quite as used to it in these rural environments. And that means that it's going to be a particularly high cognitive load for that person. So it's a great idea in these situations to have a nurse partner or part of a nurse-physician dyad running these codes, having a nurse leader. It frees up that person's brain, the person who may not be quite as familiar with running codes, to really think about things and utilize or allow more of their bandwidth to be mental bandwidth to be utilized thinking about that stuff. On the other end of the spectrum, at very large tertiary and quaternary centers where we're offering advanced modalities like ECMO, it can be very, very important as well, because at that point, when we're on the cusp of either thinking about, prepping to, or actually initiating and starting someone on extracorporeal life support, having a nurse team there running the mechanics, running the logistics of the code, doing really good ACLS is critical to getting to that next level. And in terms of the physician involvement, that physician's going to have to be, or that physician team is going to be very involved in the high task load scenario of cannulating someone for ECMO. And they really can't use much of their brain energy to also manage chest compressions and medications and all that other stuff. So particularly good in both those settings. Now, there are some limitations to what I'm suggesting, and I wanted to go over those. First, you have to have foundational systems and skills in place, and everything has to be solid. So you already have to be really good at ACLS. You already have to have a really good response program on the floor. You already have to have a lot of pieces of the puzzle in place and a solid foundation before going ahead and starting something like this and rolling something out like this. There has to be a lot of training and education. When we look at this practically at other institutions, what they've learned as part of rolling these out as QA, QI programs and performance improvement in programs to improve their in-hospital cardiac arrest mortality. Nurses are taught this stuff, and they are super strong leaders and intelligent, but they're not used to stepping up in front of a whole bunch of physicians and actually running the code and telling people what to do. And that seems to be a regularly occurring pattern. There's nothing wrong with that. It's just a function of training in that role. You feel less comfortable when you haven't done it before. So the training and education has to be interdisciplinary, and it has to empower nurse colleagues to actually take on that role and boss me around and tell me what to do and tell me to back off if I'm intruding and actually starting to become way too involved in that stuff. And that's okay. It takes time. And when it takes time, it means it's not just initial training and education. It's regular, focused, deliberate practice. Looking at quantitative metrics, seeing how long it takes us to actually take on that role. How many times in real codes when we debrief and look back did we actually do it? What are our times to response? Is it actually helping? Are we figuring out the underlying problem quicker? Is it actually having someone dedicated, having a nurse leader dedicated to this scenario? Are we actually minimizing our time off the chest? Are we actually doing some of these metrics better? It takes buy-in from other services and disciplines, right? So everybody has to be on board, and this means that we have to talk to all of the parties who are involved to make sure that from the rapid response teams or medical emergency teams, the anesthesia team, the ICU team, the emergency department team, all of the teams that might be involved in running a cardiac arrest are on board with this and support it. Finally, you have to have an engaged and supportive nursing leadership that will advocate very strongly for the nurses and support them in these roles and provide time to pull nurses off the floor and train them, to provide the money, so we're paying them to actually do this training and empowering them by giving them opportunities to step into these roles, as well as advocating on the backside to making sure it's actually happening. So we talked a little bit about the science of stress and cognition and how we think underneath in these very stressful situations. We talked about team resource management, specifically during in-hospital cardiac arrest. Then we talked about the job of the nurse captain, what that job is, what that role looks like, and why. We went through 6 reasons why I think it might be very, very important and helpful and actually improve our in-hospital cardiac arrest response. You can absolutely do it. We can empower our nurses to do it. We can actually institute these plans and these programs and nurse-led codes as part of quality improvement programs to improve survival to in-hospital cardiac arrest and our response to very stressful resuscitation situations. So I invite you to give it a try. Thank you so much for your time and actually watching this short video. And if you would like, this QR code will take you to a list of references that I use to make this talk, or you can go to tinyurl.com/nursecodecaptain, and it will also take you to that list of references. And always feel free to reach out. My Twitter handle is @ResusPadawan, and my email is mjloria@salud.unm.edu. Thank you so much for your time and attention. Take care and stay safe.